Welcome back everyone. Today we are going to see the fourth lecture, that is management of drug sensitive tuberculosis. Previously in the three videos we have seen introduction and basic pathogenesis of childhood tuberculosis, the pediatric tuberculosis diagnostic algorithm and the pulmonary tuberculosis, the extrapulmonary tuberculosis, and today we are going to enter into the management part. For the ease of discussion, I have decided to divide the video on management of drug sensitive tuberculosis into two parts. In part 1, we will be discussing the basis of pharmacotherapy and the basic management of tuberculosis. And in part 2, we will be going to discuss the clinical follow-up, monitoring and adverse drug reactions, which will be coming in the next lecture. So the outline of today's discussion will be the basis of pharmacotherapy in tuberculosis, what are the recent changes in the management program, what are the case definitions, what is the basic management protocol of tuberculosis, what are the adjunctive therapies that we need to give, and how to diagnose and manage perinatal tuberculosis, and how to manage a newborn born to a mother with active tuberculosis disease. So coming to the basis of pharmacotherapy, there are several determinants of choice for basis of anti-tubercular drugs. How the anti-tubercular drugs have been decided. There are a lot of determinants. Some of those are the bacillary load, the metabolic subpopulations, quickly dividing or slowly dividing bacterial populations like that, drug resistant strains, lag period of bacterial subpopulation, the pharmacokinetic profile of various drugs in the body, and the pathological factors, etc. So these are the several determinants of choice on the basis of anti-tubercular therapy. Now coming to the anti-tubercular therapy, we know that a varieties of drugs are used or a combination of drugs are used. Why? Because to attack all the various subpopulations of bacilli. For example, intracellular bacilli and extracellular bacilli, fast growing bacilli and slow growing bacilli. There are various subpopulations of bacilli present in the body of a person suffering from tuberculosis. So to attack all those subpopulations, we use a combination of drugs. The therapy of tuberculosis consists of an initial phase known as initiation phase and a later phase known as continuation phase. So the initial phase is characterized by a higher bacillary load, a higher chance of naturally occurring mutants. So a higher number of drugs is needed to combat these problems. And the target or the goal of therapy with higher number of drugs is to early and rapidly kill the bacilli for the prevention of deterioration and death, to reduce the infectivity of the person and to achieve the sputum conversion. So in the initiation phase, as the bacillary load is high and the chance of occurring natural mutants is high, a higher number of drugs are needed so that we can kill the bacilli earlier and rapidly, we can prevent deterioration and death, we can reduce the infectivity and we can achieve a sputum conversion successfully. While in the later phase, the smaller number of bacilli are left because the majority of bacilli are killed by our effective pharmacotherapy. So a lesser number of drugs are needed, and the goal of therapy in the continuation phase is to eliminate the residual bacilli and to reduce the chance of failure and relapse. That is the basis of pharmacotherapy of tuberculosis. That's why the treatment pattern has been divided into initiation phase and continuation phase. We have to remember one number, that is 21. 21 hours is the dividing time of tuberculous bacilli. So all the drugs are administered in such a way that they achieve peak concentration at the same time so that we can hit the bacilli hard. That's why all the anti-tubercular drugs are taken, first line drugs mainly, are taken once daily early in the morning. So why many types of drugs are used or a combination of drugs are used? Monotherapy is a big no-no in tuberculosis. Why? If we take the example of these first line drugs, these are the five first line drugs: isoniazid, rifampicin, pyrazinamide, ethambutol and streptomycin, commonly known as HRJDS. We can see that all the five have different mechanisms of actions. All the five have different method of killing. While four of them are bactericidal, one of them is bacteriostatic. Some of them kill the extracellular bacilli, some of them kill the intracellular bacilli, Some of them more effectively kill the fast or rapidly dividing bacilli or fast growing bacilli. Some of them kill more effectively the slow growing bacilli or the slowly dividing bacilli. Some of them act better in the acidic pH. Some of them act better in the alkaline pH. All the drugs have different mutations, different mechanisms of mutations, and different genetic loci of mutations. So as these 5 drugs act in different ways and they have different mechanisms of actions and they have different modes of resistance, so that's why polytherapy or multiple combination of drugs is the basis of pharmacotherapy in tuberculosis. One single drug will not act or will not be helpful. So what are the recent changes in tuberculosis management plan? The tuberculosis management plan has changed drastically in the last decade. 10 to 15 years of this used to be completely different. There used to be 3 categories, later it became 2 categories. Drugs used to be taken thrice weekly. Lots of things were there. So what are the changes, recent changes made in the tuberculosis management plan? First thing is the intermittent therapy has been changed to daily treatment. Previously, there was 3 doses to be taken in 1 week, but now daily. That means every medicine has to be taken every day. Second thing is category 2 regimen has been abolished. Previously, there were 3 categories, 1, 2, 3. Then it became 2 categories, category 1 and category 2. Now there is no category, only pharmacotherapy is decided based upon the diagnosis. So category 2 has been abolished. Third thing is there is no extension of initiation phase. If no response is seen at the end of initiation phase, the patient is evaluated for drug resistant TB rather than extending the initiation phase. Earlier what used to happen, suppose after 2 months of initiation phase the patient has not achieved sputum conversion. So what used to be done? The initiation phase used to be extended for 1 month, 2 plus 1 it used to be called. So that is not done now. If a patient has not responded after 2 months of initiation phase, the patient has to be evaluated for drug resistant tuberculosis and if found has to be managed accordingly. So that is the recent change. Next thing is addition of ethambutol in the continuation phase. Previously, the continuation phase used to consist of only 2 drugs, that is H and R. Now it is H and R and E, 3 drugs. So addition of ethambutol in the continuation phase. Next is combi packs or patient-wise boxes. Those have been changed to fixed drug combinations. We will discuss that in a shortly. Next thing is all rifampicin sensitive cases are given standard therapy even if previously treated. No more classification as new or previously treated. Previously there used to be classification based upon if a person has taken anti-tubercular therapy before or not. If a person has not taken anti-tubercular therapy or taken anti-tubercular therapy for less than 1 month in his lifetime, that used to be considered a new case. And if the person has taken more than 1 month of anti-tubercular therapy previously, that used to be considered a previously treated case. And the treatment used to be different for both the scenarios. But now, new or previously treated doesn't matter. If it is rifampicin sensitive, it is treated as drug sensitive tuberculosis and given standard therapy. If it is rifampicin resistant, it is treated as drug resistant tuberculosis and given the therapy available for drug resistant tuberculosis. Is there is new regimen for INH mono and poly resistance. Previously it was not there. There was only drug sensitive resistant or multi drug resistant. But now there is a new regimen available for INH mono or poly resistance also. And adjunctive surgical therapy for certain cases like spinal compression is recommended in the National Tuberculosis Elimination Program. So these are the recent changes in tuberculosis management plan than before, and this is subject to change also because tuberculosis is something, the treatment is very dynamic. The treatment recommendations change from time to time. So 5 years later this might not be the case. Some of these things might change also. So what are the case definitions that we need to know? First thing is new case. As I told before, a new case is any patient who has never had treatment for TB or taken ATT for less than 1 month. ATT means anti-tubercular therapy. Recurrent TB case. What is a recurrent TB case? Recurrent TB case means suppose a person has been previously successfully treated, that means cured or treatment completed, full course of treatment given. Now again the patient has come as a case of microbiologically confirmed TB. Microbiologically confirmed TB means either nucleic acid amplification test has been positive or acid fast bacilli have been seen in the smear. Next is what is treatment after failure. Treatment after failure means patient has failed treatment previously and now again has come with diagnosis of TB. Previously treated for TB but treatment failed at the end of the most recent course of treatment. That means the most recent course of antitubercular therapy that has been provided to the patient has failed. At the end of treatment, the patient has not either symptomatically improved or the patient is still sputum. The patient has not achieved sputum conversion. Next is what is treatment after loss to follow-up. Treatment after loss to follow-up means previously the person has taken for more than 1 month. That means not satisfying this criteria. It is not a new case. Previously treated for more than 1 month, declared loss to follow-up. Patient has stopped treatment due to some reason, and in most recent course of treatment, now patient has come with again a diagnosis of microbiologically confirmed TB. So patient has taken ATT for more than 1 month, stopped due to some reason, and now again has come with a diagnosis of TB. That is called treatment after loss to follow-up. And other previously treated cases means previously treated for TB, but outcome after the most recent course of treatment is unknown or undocumented. That means suppose patient has taken ATT or antitubercular therapy for more than 1 month, but at the end of the treatment, whether the patient was cured, whether the patient had treatment completed, whether the patient has had treatment failure, nothing is known. The outcome is unknown or undocumented. That is called other previously treated case. So, if we think there can be these 5 categories of tuberculosis patients. First, new microbiologically confirmed rifampicin sensitive pulmonary TB. That means the patient is a case of pulmonary TB. He is not drug resistant. Patient is rifampicin sensitive. He is microbiologically confirmed. That means NAT or acid fast bacillicin, and it is a new case. That means taken ATT for less than 1 month or not taken at all. Second category is new clinically diagnosed pulmonary TB. That means all things remain same. The only thing that changes is microbiologically confirmed changes to clinically diagnosed. Similarly, new microbiologically confirmed extrapulmonary TB, new clinically diagnosed extrapulmonary TB. And by definition, this is all rifampicin sensitive. Last part is drug sensitive previously treated TB, which can be previously treated means this can be recurrence, this can be treatment after loss to follow up, this can be treatment after failure. We learned the definitions just now. So all these categories, the important thing is to remember that in spite of having all these categories, the treatment remains same. The golden line of treatment is 2 HRJD plus 4 HRE. That is the treatment for all. It may be pulmonary, it may be microbiologically confirmed, it may be clinically diagnosed, it may be extrapulmonary, it may be microbiologically confirmed, clinically diagnosed, it may be a previously treated case, but all the cases have same treatment. 2 HRJD plus 4 HRE. What does it mean? 2 months of 4 drug therapy taken daily, 4 months of triple drug therapy taken daily. So total is 6 months of antitubercular therapy. This is the standard for all, except two special scenarios that we have to remember, except neurological TB and spinal TB. In those cases, it is not 2 HRGD plus 4 HRE, it is 2 HRGD plus 10 HRE. That means here the total treatment duration was 6 months, here the total duration is 12 months. The duration of intensive phase remains same or initiation phase remains same, but the continuation phase changes from 4 months to 10 months in case of two special scenarios, that is neurological TB and spinal TB. Then what we need to remember, molecular testing is to be done in all the new cases at the diagnosis itself, and all these cases, all the previously treated cases have to be considered as suspects for drug resistant tuberculosis, and they have to be evaluated in line of drug resistant tuberculosis algorithm. We have to find out that this is a previously treated case means this may be a case of drug resistant TB, and whether it is drug resistant or not. If not drug resistant, this treatment has to be given. If drug resistant tuberculosis is found, then the treatment line is completely different, that we will learn later on. Now coming to the first line drug, these are the 5 first line drugs H, R, Z, E and S. The dosage range is 7 to 15 milligram per kg per day. Rifampicin is 10 to 20 milligram per kg per day, 30 to 40 milligram per kg per day for pyrazinamide, 15 to 25 for ethambutol and 15 to 20 for streptomycin. And this is the maximum range. But for easier remembering, what we need to remember is the average. 10, 15, 35, 20, 20. We all know HRJDS, so we just need to remember the letters. 10, 15, 35, 20, 20. 10, 15, 35, 20, 20. That means 10 milligram per kg per day of isoniazid, 15 milligram per kg per day of rifampicin, 35 milligram per kg per day of pyrazinamide, 20 for ethambutol and 20 for streptomycin. So this is the average dose range of the first line drugs. So now coming to fixed drug combinations. This is one of the recent changes that we learned before. So what are the fixed drug combinations? The fixed drug combinations means a combination of medicines or combination of drugs with fixed dose in them. So what is the advantage? This is a safe and simplified thing. This avoids errors in missing one or combination of drugs. Suppose a patient has to take HRJD, 4 drugs. If we give a separate tablet for each 4 drugs, there is a chance that the patient may miss one of them. But if we give one tablet which contains HRJD all 4, the patient will take one tablet and there is no chance to miss the drug. So that is the advantage. Third thing is it reduces the risk of emergence of drug resistant trends. As much as the patient takes the appropriate therapy, there will be less chance of evolution of resistant strains. So if we give all the drugs by a single tablet, the patient will not miss any drugs and there will be less chance of evolution of a drug resistant strain. Next is it simplifies the drug supply management, shipping and distribution, because one tablet has to be transported in place of 4 tablets. So what are the fixed drug combinations available? One adult combination is available, one pediatric combination is available. For adult fixed drug combination or adult FDC, two types of FDCs are available, 4 FDC and 3 FDC. What is 4 FDC? 4 FDC is for initiation phase. So what is 4 FDC? 4 drugs, HRJD, 75, 150, 400 and 275. What is 3 FDC? It is for continuation phase, HRE, so 75, 150, 275. So it is very easy to treat because our treatment was 2 HRJD plus 4 HRE. So all we have to give is, during initiation phase, we have to give 2 months therapy with one patient has to take one tablet of this 4 FDC tablet, one tablet containing this, so that the patient will get all 4. And after 2 months, for next 4 months, the patient has to take one tablet containing these 3 drugs. So treatment is very much simplified. That is the adult FDC. But pediatric FDC is slightly different. First thing that you need to remember is pediatric FDC doesn't contain ethambutol. Ethambutol has to be taken separately. That is 100 milligram. So removing ethambutol, what else remains in the initial phase? HRJD minus E, that means HRZ, and continuation phase HRE minus E, that is HR. So for pediatrics, 3 FDC is available for initiation phase and 2 FDC is available for continuation phase. For initiation phase it is HRZ and the doses are obviously slightly lower, 50, 75 and 150, and for continuation phase it is 50, 75. So now if we represent one adult FDC by one A, one pediatric FDC by one P, and one ethambutol tablet of 100 milligram by one green tablet, so if we take this pictorial representation and think how to give the drugs. So the drugs have to be given depending on various weight bands. For childhood tuberculosis, there are 6 weight bands. 4 to 7 kilo, 8 to 11 kilo, 12 to 15 kilo, 16 to 24, 25 to 29 and 30 to 39. For every 4 to 7 kilo child, the patient has to take one pediatric FDC and one ethambutol. For 8 to 11 kilo child, each patient has to take 2 pediatric FDCs and 2 ethambutol tablets every day. Similarly, 12 to 15 kilo, he has to take 3 pediatric FDCs and 3 ethambutol. 16 to 24, he has to take 4 pediatric FDCs and 4 ethambutol. When the child becomes 25 to 29 kilo, he has to take 1 adult FDC, 3 pediatric FDC and 3 ethambutol tablets. And when the child becomes 30 to 39, he has to take 2 adult FDC, 2 pediatric FDC and 2 ethambutol FDC. If we take how much drug total dose the child receives by taking this and divide by the weight, we will get that the weight criteria satisfies. That means each drug he will be getting at the requisite milligram per kg per day. That will be close. Accordingly, this weight band has been prepared. So what are the indications of steroids in tuberculosis? This is one of the most favorite questions of Viva examiners in UG final exams, in PG final exams, bedside classes. This is one of the most favorite questions. When do we use steroids in tuberculosis? So these are the definite indications. This everyone has to remember, and this is important in competitive exams also. Tubercular meningitis, tubercular pericarditis, Addison's disease, biliary TB with alveolo-capillary block, and tubercular uveitis. These are the five definite indications where steroids have to be given, and some other indications are there where you may or may not consider giving steroids is endobronchial tuberculosis, bronchial compression, mediastinal compression syndrome, pleurisy with severe distress, laryngeal tuberculosis, and TB iris. We will learn what is TB iris very soon. So these are the indications of steroids in tuberculosis. These are the definite indications. These five you have to remember every time, and these are the probable indications where you may or may not use steroids depending on your clinical judgment and expert opinion. So why do we use steroids in tuberculosis? Steroids are used because steroids are useful in decreasing in the inflammation related injury, the reducing the mortality in pericardial disease, it improves the outcomes in intracranial tuberculosis, it reduces the development of hydrocephalus and vasculitis, it suppresses the inflammatory response caused by interaction of interleukin 2, interferon gamma and microbial factors. So when we start antitubercular therapy in a patient, there will be killing of the bacilli, so that will release inflammatory markers, so that will lead to inflammation related injury. And when there will be pericardial disease, it is obviously a severe form of tuberculosis which has a high mortality. And intracranial tuberculosis, as we learned, tubercular meningitis is the most severe form of TB that we can encounter. We already know the known complication of tuberculosis due to basal exudates, that is hydrocephalus and vasculitis, and there will be inflammatory response mediated by interleukin 2, interferon gamma and microbial factors. All these mechanisms are immune mediated mostly. So to reduce those immune mediated injuries, we have to give steroids, and the steroids are helpful in preventing all this. What steroid we give? We give steroid prednisolone 1 to 2 milligram per kg per day, or dexamethasone 0.6 milligram per kg per day, or equivalent doses. Equivalent doses of other steroids we can also give if these steroids are not available. And the duration of therapy is we have to give this dose for 2 to 4 weeks, and then the steroids have to be tapered over next 4 weeks. That means total 6 to 8 weeks of steroid therapy has to be given. Out of this, initial 2 to 4 weeks are the full dose, and later on the 4 weeks has to be tapered. So what is adjunctive pyridoxine therapy? In INH or isoniazid interferes with the pyridoxine metabolism competitively and causes peripheral neuropathy. That's why every patient that receives INH has to receive pyridoxine additionally. And INH is a part of both the initiation phase and the continuation phase. That means as long as the patient receives antitubercular therapy, he also has to receive pyridoxine at 10 milligram per day for all the patients. And the rationale is the increased dose of INH from 10 to 15 milligram per kg per day. Previously it was 7 to 10 milligram per kg per day, but now the dose of INH has been increased in NTEP from 10 to 15 milligram per kg per day. So there is slightly higher risk of peripheral neuropathy. That's why pyridoxine has to be given to all. And there is high prevalence of malnutrition in tuberculosis also. So malnutrition means the child will also have pyridoxine deficiency. So to counteract that deficiency, patient has to be given pyridoxine also. So what is congenital tuberculosis? Three main infectious routes are there by which a neonate can suffer from congenital tuberculosis. First is transplacental route. And if the patient gets infected by transplacental route, the primary complex will be in the liver. If the patient gets tuberculosis infection by aspiration of infected amniotic fluid, the patient's primary focus may be in the lungs. And if the patient gets congenital tuberculosis by ingestion of infected amniotic fluid, obviously the primary focus will be in the gut. So how do we diagnose congenital tuberculosis? We diagnose congenital tuberculosis by the modified Cantwell criteria, and the congenital tuberculosis has very high mortality rate, that is up to 50%, especially those presenting before 4 weeks. Similar treatment regimen is followed for pediatric TB and congenital tuberculosis. What is modified Cantwell criteria for congenital tuberculosis? An infant must have a proven tuberculosis lesion. Lesion can be where? In the liver, in the lungs, or in the gut, depending upon the method of acquirement as we discussed in the previous slide. And this, along with this, One of the following must be there. What? Lesions in the first week of life. Next is primary hepatic complex or cageating hepatic granuloma. Next is tuberculous infection of the placenta or maternal genital tract. And last is exclusion of possibility of postnatal transmission by a thorough investigation of contacts, including hospital attendance, and by adherence to existing recommendations for treating infants exposed to tuberculosis. Along with a proven tuberculosis lesion, there must be one of these four. If it is present, we can possibly tell that the child might be suffering from congenital tuberculosis. So how do we manage a neonate born to mother with tuberculosis? First thing is anti-tubercular therapy should be given to pregnant women having tuberculosis. First line drugs except aminoglycosides are safe in women, and a woman's health is of paramount importance. That means pregnancy is not a contraindication for anti-tubercular therapy, and all the pregnant women suffering from tuberculosis must be given anti-tubercular therapy with all the first line drugs. What is the risk of transmission of infection to newborn? The risk of transmission of infection to newborn is higher if the mother has miliary, meningeal or pulmonary disease, if the contact cough etiquette of the contact is very bad and the contact is very closely associated, if isolation and barrier nursing are not followed, and if preventive therapy has not been given. Last, newborn to be examined as soon as possible. When a newborn is born to a mother with known case of tuberculosis or known diagnosis of tuberculosis, the clinical examination has to be done, a chest radiograph has to be taken, and the gastric aspirate has to be sent for nucleic acid amplification test, or ultrasonography may need to be done depending upon the presence of symptoms. What is preventive therapy to neonates? If a neonate is born to mother with any form of active TB during pregnancy or after birth, the child has to be given INH preventive therapy, that is isoniazid preventive therapy, 10 mg per kg per day for 6 months along with pyridoxine. But before giving this isoniazid preventive therapy, active TB disease and multi-drug resistant contacts should be ruled out first, because if active TB disease is there, monotherapy is a big no-no as we discussed before, and the patient has to be given complete therapy as per the pediatric TB regimen. Separation of mother and neonate is not required, and separation of mother and neonate is only done in special scenarios, such as if the mother is sick and requiring hospitalization, if the mother is non-adherent to the treatment, and if the mother will be non-adherent, there will be chance of severe form of tuberculosis and the risk of transmission to infant. If the mother has drug resistant tuberculosis, because a drug resistant tuberculosis in a neonate will be very difficult to manage, so if the mother has drug resistant tuberculosis, better to separate her from the child, and patient has to continue breastfeeding. Malnutrition causes a lot of death, so patient has to be continued breastfeeding irrespective of the TB status of the mother. That is a very important thing to know. And BCG vaccine birth dose is to be given. No prior tuberculin skin test before starting isoniazid preventive therapy. That is a must. BCG vaccine has to be given to all, and strict personal and cough hygiene has to be undertaken. So what are the key learning points in today's session? Multi-drug therapy always in tuberculosis, no monotherapy ever. We have to think carefully before choosing empirical antibiotics in case of suspected community acquired pneumonia, because in a case of suspected community acquired pneumonia, if we start any drug with anti-tubercular effect initially, and suppose the patient is originally having tuberculosis, the symptoms will transiently improve and later come with drug resistant tuberculosis, that we discussed in our second lecture also. Third thing is 2 HRJD plus 4 HRE for all, and only in case of spinal and neurological tuberculosis we have to give 2 HRJD plus 10 HRE. Steroids in special situations, the 5 indications we learnt, most important of them is tubercular meningitis. Pyridoxine has to be given to all, and isoniazid preventive therapy for 6 months to neonates born to mothers with active tuberculosis disease. These are the key learning points of today's session. So if you like this video, please press like, share and subscribe with your friends. Thank you.